Hi, and thanks for listening. My name is Brian Bezic, and I practice in pulmonary medicine in Boise, and I'm a PA there. We are coming to you from the first ever APAPP Conference, and this is a conference for PAs and NPs in pulmonary medicine. First time we've ever had a meeting, and it's been very successful. We're in Las Vegas, and rumor is next year we're in Nashville. So if that's something people are interested in, please sign up and be a part of this organization. We're going to talk about inhalers today and some of the changes that have happened with inhaler therapy, especially GINA guidelines over the last few years. And I want to introduce my co-host, Tyler. Take it away and tell us about yourself.
Good. Well, thanks for having me, Brian. Good morning, everybody. Tyler Cook here, pulmonary nurse practitioner and APAPP board member as of this year. And we're excited to be here in Las Vegas for our first annual conference that has, I think, exceeded expectations in terms of attendance. And I'm happy to be here to talk a little bit about asthma, have a kind of an organic discussion about kind of where things have been going and changing with GINA guidelines and inhalers.
Yeah, I like, and hopefully people listening, if you're in pulmonary medicine, maybe some of this is review, but if not, if this isn't something you are able to keep up on, we can maybe catch up, because GINA, the guidelines for asthma, we have some US-based guidelines. Those are updated very somewhat sporadically, and the last update was a partial update at best, and it took 6 years to get that update out. So by the time it was done, there was some of that information was kind of old. But we have GINA, which is updated annually. Sometimes even there's a mid-year update. So a very good set of guidelines for us. And GINA has tried over the last few years to make some big changes. One of them was, hey, don't just place patients on albuterol. This is what GINA is saying. Now, the US guidelines are still a little bit different, but they said, if you're going to start somebody on anything and they have asthma, start them on a beta agonist that's short acting like albuterol, but you need to add a second medicine, in this case, something that controls inflammation in an inhaled corticosteroid. So that was their recommendation, and now we have an inhaler. Any experience with the new inhaler that has albuterol and a steroid in it with it combined?
Yeah, I know that it's just hit the market. I personally have limited experience with it because I've actually kind of adopted that whole kind of smart therapy with the ICS formoterols, over the last couple of years with the GINA guideline changes. And I think it's kind of been exciting because I do see a fair amount of asthmatic patients all the way from mild intermittent to, severe. And for those mild intermittent patients, they're the ones that have kind of been forgotten about for, decades. It's been here, take albuterol,
Yep.
and see what happens. And I feel like now there's more of an opportunity to kind of have those conversations about that there's better therapies available now. And we're seeing the importance of adding in that inhaled corticosteroid component in terms of reducing exacerbations or kind of having them start something when their symptoms are starting to act up. And that's a big change because it's kind of changed the way to have a conversation with those patients and offer them new therapies.
Yeah. So, I mean, it's an option for patients to use a rescue inhaler that doesn't just dilate the smooth muscles. So, I mean, albuterol has actually other functions, but its primary job is we want to take those tight muscles and relax them, open up the airways. That's the goal. But it really doesn't address inflammation, not directly. And so, and overuse of albuterol is a big problem. And at time, it just gets less effective. And so there's all kinds of issues with overuse of albuterol. So adding that second component in can be helpful. So it's a rescue inhaler that has albuterol and then a second component, budesonide, which is for inflammation. And those two together can be pretty helpful. But UT is smart therapy. So that's the other big change that has come out. And GINA pushes that very hard. Their guidelines for 2024 have 2 rows, in fact, and the top row is the SMART row, and it's the preferred method. So how are you using SMART now? What are you doing with that?
I think especially with my mild intermittent patients, I think it's having a conversation first. I think really kind of empowering a patient to first of all understand what is asthma, and I think the big takeaway is to understand it's the airway inflammation is the issue, right? And albuterol alone doesn't deal with that. And so when you add in something like an ICS formoterol, you're getting that bronchodilation, but then you're getting that anti-inflammatory effect. And I think it just kind of allows you to have a conversation with your patient to put the tools in their toolbox. I say, you have this this inhaler, you can take it as needed. But I'll take it a step further and say, wildfire smoke exposure. I live in the Pacific Northwest. It's been kind of a nightmare last few summers. And your symptoms might become more persistent. You can then kind of take this 2 puffs twice a day as kind of a maintenance medicine. So you can kind of alternate back and forth between those two. And you have the tools in your toolbox to kind of manage your asthma. And that's a new thing especially for mild intermittent asthmatics that we were never really doing, because we were just giving them albuterol and saying, have at it.
And have at it, yeah. And patients are really good. They like to change the prescriptions anyway. So they're like, I'm going to do what I want to do. And I think the idea with SMART is great. I mean, and SMART itself, I guess, is single, like the S in SMART is single, maintenance, and reliever. So I've got one inhaler. Instead of giving you 2, I'm going to give you 1 inhaler. And this inhaler is your rescue inhaler. Use it as needed as a rescue inhaler. Also, though, it lasts for 12 hours. I mean, that's the idea. And I usually tell patients, hey, this has albuterol in it, but it's a kind of albuterol that's going to last for 12 hours. So it's onset pretty quick. Within a minute or so, it's starting to do its job. But it's going to hang out a lot longer. And so this gives you a tool, like you said, in the toolbox that I can use as needed when I'm in a pinch, when there's smoke coming over, cascades, there's fire and there's offshore wind and it's blowing it right into Seattle. You can tell people, hey, you've got this option that's going to work when you need it. It's also then going to stay with you the rest of the day. And that's a great option. And up to 12 puffs a day is very safe, documented, very safe for an inhaler. But now the inhaler SMART therapy, can we use Advair? Can we use formoterol? Can we use any other long-acting beta agonist, or it's the one that's in generic Symbicort now that we can use, right?
Yeah, I think the recommendation is ICS formoterol. So I think that you're looking at Dulera and Symbicort, and then I think now we have a generic Symbicort Breyna. Right. So with me, I'm like, we're playing insurance games all the time.
Yeah.
What's your insurance going to cover? They're going to cover generic Symbicort, whatever, as long as it's the formoterol component. I think the issue is formoterol compared to some of the other LABAs, they feel it quicker. I think that's the feedback you get is when they're inhaling that formoterol, they feel it pretty quickly.
Yeah. That onset is they can feel it working, which then they're much more likely to use it, right? Yeah. So, yeah, and I love the idea of doing that. We had a conversation about biologics just a few minutes ago, and the topic that comes up with biologics is if they're on a biologic and they're doing really well, and you're thinking about backing them down, I like SMART therapy for those patients. So maybe in the past they've been on whatever inhaler twice a day, and they did it pretty religiously because they weren't controlled. Well, now they've been controlled, and we get to that 6th or 7th month window of good control, and you're starting to think that, well, for the right patient, this is not everybody, for sure. You don't want to increase the risk of ending up in the ER or urgent care, but for those patients, you might be able to back them down. And then when they come in, you can say, okay, you had this ICS formoterol inhaler, and it was as needed or twice a day, depending on your situation. How often did you use it?
Yeah.
And then now all of a sudden that frequency of use becomes like an ACT. I'm getting an idea of their symptoms and their control based on how often they're using it. A lot of good information when they tell you that.
Yeah, and you bring up a good point about biologics and de-escalation, and this is something I think I like to deal with at every follow-up visit for an asthma patient is de-escalation appropriate, and what does that look like, right? And we have some great guidelines, to kind of outline how to do that, but it's obviously very patient-specific. I think when it comes to patients on biologics, they're supposed to stay on their therapy, but the reality is they may not need to. But I think always having it available in case that they're, experiencing some sort of, flare-in symptoms for whatever reason, if they're sick or some type of exposure, that they have that. Because the patients do much better on the biologics. So sometimes we can back off on things, but always evaluating at every visit, what's your medication regimen? Is this appropriate? Can we change it? And really keeping a kind of a close eye on them at follow-ups.
Yeah. And the idea here is this is a tool that works quick enough. So if let's say they did taper down for whatever reason, they were doing well. If they need to ramp back up, because the effectiveness, the efficacy is quick, and it's all day, it's okay to go ahead and ramp up. If Tuesday you decide I needed to go up in therapy for whatever reason, and you start this on Tuesday, it works on Tuesday.
Yep.
And so I'm not having to start something up and wait a while. And my one beef about like fluticasone was that it just wasn't. And when you have fluticasone with salmeterol, it just didn't have that kick, and it didn't have that onset of action. With formoterol being so quick, it gives us that option. And it is weird sometimes now, if you haven't done this, to say, here's one inhaler. You've had two for the last 20 years of your life, and we always wanted you to carry those two. This is one, and it's kind of the best of both worlds. And if this isn't working, that's fine. We can always do it twice a day and add in other therapies. But this is one inhaler, which patients like that idea, and it does what we're saying. And so and I will just say that the data that, especially in the GINA report, if you get that, the data is that every aspect of asthma control went up with SMART. It wasn't like it helped FEV1 and it helped in lung volumes, it helped in exacerbation prevention, symptom reduction, even things like sleep were better. And so, as well as patient satisfaction. So when you have all those check boxes, like literally pretty much every box that you could check in a desire with a new therapy, SMART therapy met all those criteria. So it is a good option for a lot of those patients, especially like in the middle that you said, those mid-range asthma patients.
Yeah. I also think, just kind of on a side note, when we're thinking, possibly pregnant or breastfeeding women, I think the data for most inhalers, it's pretty safe, but I think budesonide and formoterol have the most research behind them in terms of safety data. And so it's nice that even if you have a mild intermittent asthmatic that might be pregnant, you can feel confident that that those medications also are pretty safe and effective for them and for that particular population.
Yeah. So now I guess, and that's maybe the if we're summarizing GINA the last few years, one was, hey, don't just use albuterol, but have an albuterol with a steroid. So that's going to be appropriate for a lot of patients. I like the brand name is Air Supra, but I like that for. I use it for exercise-induced bronchospasm for those patients with truly mild asthma. And I don't know, we got to remember the rule of twos. You don't want them really using that rescue inhaler more than twice a week. That doesn't necessarily apply to SMART therapy, but if it's just you're treating them as mild asthma and they're using it twice a week or less, they're going through 2 inhalers a year or less, they're not getting up at night, too often, and they're meeting that rule of twos, that truly means this is a very intermittent, well-controlled. If they've ever been in the ER for asthma, they don't fall into that category in my mind. Like even one visit, they are in a different category if it was for asthma. And it's a good option for those patients that are really well-controlled. I do try to ask, when did you use your inhaler? Either SMART therapy or just using an albuterol with steroid. What made you think, in my mind, I need my inhaler? What happened? And then they can tell you, well, I was coughing or I was wheezing or whatever. And then you say, okay, did it help? And they're like, yeah, I did my SMART therapy, or I did my, my Air Supra, and it helped. How long did it take? Well, it kicked in about 6 hours later. I'm like, okay, well, that wasn't the inhaler. So trying to find out what was the event that made you reach for your inhaler? And did that event get better? Like if you did the inhaler, was that thing, coughing, wheezing, whatever, was that better really quick? And if somebody says, I went through an inhaler in a month, well, one rescue inhaler like this, if you're talking about Air Supra, 200 puffs. I mean, that's 100 events, or albuterol has 200 puffs. That's 100 times in a month. You thought, I need help. And that's right. That's way too much. So those patients that are really well controlled, I like that. But when you get anywhere past that middle road that you kind of alluded to, in that case, we have ICS formoterol. And I'm trying to think of reasons that I wouldn't give it to that group, like why I wouldn't give them SMART therapy. I don't know. Any red flags for patients that shouldn't be on SMART therapy? What do you think?
I can't think of anything other than patients that just are uncontrolled in general, and then of course we'd be putting them more on the persistent spectrum of the spectrum, and then follow up. I think that's just the big thing, is really kind of empowering these patients with, they understand what their disease means and how to treat it. But I think that this is a huge step forward in kind of a population that we kind of didn't do much with for many decades.
Yeah. And the hope is that they'll kind of own this. And again, I think patients were already doing a little bit of SMART therapy on their own. They wouldn't fail whatever the rescue, and they'd have this. Or so many patients come in, they're on fluticasone and they say, well, I only use this in emergencies. And I'm like, that's exactly opposite. If it's noon like I said, on a Tuesday, and you're sick and you're not breathing, and you did, 4 puffs or 6 puffs or whatever they're doing with fluticasone, that's not really addressing the issue at noon on a Tuesday, right? That may help you by 6 o'clock that night or 8 o'clock that night, but so it's just not addressing really their issue. So hopefully now we're taking those patients that were kind of doing that already and giving them a little more structure. And I would say too, there are patients that like you tell them to use it as needed and they get this panic look and they want rules. And so I pull, okay, we're going to go back to the asthma action plan and we'll make this a rule or something and write it down. And if you're not familiar, there are very good specific SMART therapy asthma action plans that you can download, and they're all free. But so if you're not comfortable doing this and you're listening to this, I would download those because they're very good and they do kind of walk you through it and they allow you to fill in the boxes for the patient to use this as needed. But also, if you feel that you need more, add in extra puffs. And it says right on those, the one that I use, it says right on there, up to 12 puffs a day is safe. And then just like all asthma action plans, it has the yellow and the red. And so if you did that, it says go ahead and do it, but then seek care. And that's what I want to know. I mean, if you did it 12 times, okay, great. Did it work? What happened? What drove you to do that? All those questions. But at the other part is, okay, that's okay that you did that. But if I'm doing my job, we shouldn't have those days, or we should have very few of those days. So I want to know why and what I can do to maybe prevent those flare-ups and prevent their exacerbations. Any other, like if any exacerbation tips, like if they are struggling, they're coming in, they said, yeah, I have budesonide formoterol and I'm using it like 6 or 8 times a day. How do you kind of address that it's not seeming to work the way we think it should?
Yeah, like so patients that are, despite their therapy, they're still kind of flaring up. I mean, I like to evaluate those patients, obviously, and kind of see what's the possible trigger here. Are we dealing with a viral illness? Is it environmental exposure? I'll use smoke. I recently did an interview in Seattle about wildfire smoke, and we talked about, things like that. And so if you can identify an environmental exposure, like maybe we need to make sure that, we're indoors, closing windows, air purifiers, things like that. I think with a lot of our asthmatic patients too, and the allergies, especially where I live, allergy season is just a nightmare, and really having those conversations about mitigation strategies for managing allergies. So I think really when you kind of identify what the trigger is, then, you go from there. But ultimately, sometimes these patients, unfortunately, will exacerbate and they may need, PO steroids or something on top of that. And it doesn't stop me from thinking about, adding on like the singular type medications and stuff for patients that might need it, especially with the ones that have the perpetual rhinitis issues. We call it the Pacific Northwest drip.
The drip, the constant drip, the crease. Yeah. I hate the 2 V's, viruses and vaping. Those are the 2 things that I think drive most of my patient exacerbations that are not, I mean, there's some with clear atopic triggers, grass, I'll look and the grass pollen just spiked up really. I used to do the counts. So the counts on the news, I used to do those. And so I'm pretty in tune to those. So, but if there's not, I know there's nothing in the air right now and you haven't been around 10 cats in a long time. So tell me, what are you vaping with? And they're like, oh, and they drop their head because you can get away with vaping, I think, and not have people don't know that you're doing it. So that's the other trigger. But, with those patients, if they are, if they get to the point where you feel like they're doing their hair, their technique is good, they're filling their prescriptions, and they're using it pretty regularly, that's a great patient to say, okay, SMART therapy, which is this idea of as needed and then bumping up, probably isn't okay for them. Like we need to really say, okay, you need to be on this twice a day, and we need to consider, what are their biomarkers, start looking at some of those things because we have advanced therapies and, it was a different podcast, but we have biologics. So that all of these, everything we do with asthma is a treatment, but everything is also a test. How did you respond? And if somebody says, I have asthma and I did albuterol 6 times or I did SMART therapy and it didn't help, first of all, that's not really possible because it's possible, but then whatever's going on is either not asthma or this, whatever, maybe you're just sick and that's why. So these medicines have functions. Those functions aren't optional. They will cause bronchodilation given at the right dose in the right way and administered appropriately. So for those patients that kind of do the test of SMART, if you will, and they're still not controlled, that's great. You just learned a valuable piece of information. SMART isn't right for that patient at this time. So they need to be on, the appropriate dose of inhaled corticosteroid and a long-acting beta agonist twice a day, every day, maybe montelukast, and maybe they're on, Zyrtec or whatever as well. They're doing all those things. And then we have that conversation about, hey, what's the next step for these patients with symptoms that just keep going and going despite therapy?
Yeah, you got to start somewhere with these patients. And I always tell people, especially a new patient, I'm trying to figure you out. I think it's a great place to start. And I think possibly if I think anecdotally, I think now that I can do this, I think I have more patients that probably remain pretty well controlled, on smart therapy. And then undoubtedly you're going to have the patients that do advance, but that's the importance of kind of following up and evaluating, is this working? And obviously if it's not working, we escalate kind of therapy and migrate them out of that intermittent to more of a persistent asthma. But again, that's just the importance of, continued follow-up and really kind of figuring them out. It's very patient specific. I think asthma is kind of unique in that we really have unique ways to treat people because everybody's a little bit different. And you really have to work with your patient on really figuring out the best tools and what the triggers are, very individualized kind of care plans. But that's also kind of the fun part of it to me.
Yeah, and if you're listening to this and you don't practice, I feel bad for you, because it is so much fun to put together the puzzle of what their history is, what their family history is allergy driving these symptoms. You have symptoms. Okay, are allergies driving this sometime? Or is cat dander doing it? Is there things in your environment that are doing it that we can change? Or is there other, are you non-allergic? And it's just, you put that puzzle together. And usually we're successful at some point if they'll stick with us and go through the process. And it is a lot of fun to do that. And ultimately, if you get them on the right medicine and they're like, oh, especially when kids say, I ran at recess and I played kickball and I didn't cough. And you're like, oh, okay, my whole day I just made my day. That's such a fun thing. So yeah, if you don't do this, I feel bad. If you have to do things like rheumatology, I feel bad for you because this is fun. So anyway, good conversation. Thank you. Lots of changes. If you haven't gone on the Gina website, they have lots of resources. You can download things for free. They have an app that you can download, and none of this costs anything. And you can get some good information about the changes that have happened in inhalers and try to stay up to date because they really do make a difference for your patients. So thanks.
Thank you for having me.